So, thank you. So moving on, the third weapon against brain tumours is radiotherapy, and it's a great pleasure to welcome my friend and my colleague Yen, who's going to tell you specifically with regard to brain tumours where we are at.
Thank you, Mark, and thank you for inviting me to speak. So I'm going to talk to you a little bit about progress in radiotherapy as to whet your appetite for Dr. Freeman's speech talk this evening. Let's see if I can do this. So just briefly, because I don't know how many of you know what radiotherapy actually is, and there's no shame in not knowing. Many people we meet, even other health professionals, don't know what it is. Radiotherapy is essentially the use of ionising radiation in the treatment of cancer. And the simplest way to think about it is it's the use of high-energy X-rays in the treatment of cancer. And the idea is to deliver a lethal dose of ionising radiation to the tumour, causing DNA damage, and so when the cell divides, it dies. Of course, when we do this sort of experiment in a Petri dish, if you put tumour cells in a Petri dish, you can always kill all the tumour cells because you can always get enough radiation in to kill them. So theoretically, we could always cure all cancer with radiotherapy. However, sadly, this is not actually true in the clinical setting. And why is this? And this is mainly to do with normal tissue damage. Because as I said at the start, radiation affects the DNA, stops the cells dividing normally. Cells aren't clever enough, or radiation isn't clever enough to differentiate a normal tissue cell from a tumour cell. So what we need to try and do is to give radiation to a dose that would damage the cancer cells, but not cause normal tissue damage. And obviously, when we're thinking about treating brain tumours, there is a lot of damage potentially that we can do, both acutely, but more important in terms of late toxicity. And I think that Ski touched on this. So in the long term, you can cause problems with the child's IQ, with their ability to control their appetite, hormonal issues with pituitary gland problems. They can form cataracts, and they can actually form second tumours in the areas that you've given radiation to. So we really need to think about using radiation very carefully, and the way that we can limit normal tissue damage is the use of as small fields as we need to. So we limit the radiation that goes to normal tissues, try and shape the radiotherapy fields, because most tumours do not appear as squares or circles or nice regular shapes. We can try delivering the radiotherapy in a fractionated way. And what we know about fractionated radiotherapy is if you give a little bit of radiotherapy every day, that gives time for the normal cells to repair, and tumour cells aren't so able to repair, which is why we end up giving radiotherapy in lots of little bits over a six-week period for most brain tumours. So radiotherapy is a balance, trying to make sure that we give a dose that will kill the brain tumour while limiting the effects of the normal tissue, and therefore hopefully decreasing the late effects. So just briefly to think about the radiotherapy pathway, and as both Connor and Ski have talked about this, although this looks like a pathway in isolation, the decision to treat is a multidisciplinary decision. It is not the radiation oncologist's decision to give radiation. We do this as part of the multidisciplinary setting, and it's also seeing how radiotherapy fits in with all the other treatment modalities, the timing of radiotherapy in relation to surgery or any chemotherapy that's been given, both whether you need to give surgery or chemotherapy before or after the radiation treatment, radiotherapy planning, and then the actual treatment delivery. So should we treat with radiotherapy at all? And I think we've briefly touched on this on the other two talks. So we need to think about whether radiotherapy is the correct thing to use. If it is the correct thing, what is the right dose to use? And I think over years, in some tumours, this dose has come down. What's the dose per fraction we should use? We know that if we decrease the dose per fraction, so the smaller dose per fraction we use, the less likely late effects are to occur. How much of the brain should we irradiate? Should we irradiate the whole brain or just the part where the tumour is? And again, that's changed over time. What type of tissue is irradiated? So whether we're going to choose to radiate through the temporal lobes, or do you go through bony structures like the face? And that on the whole is not a good idea, because clearly a child's face is still growing and that can cause quite a lot of problems. What type of radiation is used, and I'll talk a little bit about that in the course of this talk. The use of chemotherapy with radiotherapy. So for many medulloblastomas now, we use concurrent vincristine chemotherapy to augment the effect of radiotherapy. and the age at the time of treatment. And again, Skis talks about this, that we're very reluctant to use radiotherapy in young children because we know that the cognitive outcome for these children can be devastating. So if we move on to having made the decision that actually radiotherapy is the correct thing to use, we need to think about how we're going to plan the radiotherapy and actually where the tumour is. And I think one of the big advances, certainly even in my professional lifetime, has been the use of MR fusion. So Connor has shown us beautiful pictures of MRs delineating where the tumour is, and in this you can see this is an MR with a tumour beautifully delineated. On the CT scan, it's quite a lot harder to see that that tumour is sitting there, and you certainly really can't see that that tumour's tracking down here in the way that we've drawn the volume here. And the only reason we know we can draw it like this is that we can fuse this information to our CT planning scan and actually get much better volume definition. So in the old days, we'd have to treat much bigger fields to be sure we got the tumour in. Now we are more confident that we can delineate the volume that we actually need to treat. Radiotherapy now, for all brain tumours, the standard of care would be 3D conformal radiotherapy. And by this, what this means is you have 3 or 4 beams coming in. In this case, you've got 3 beams coming in, shielding out. So this field would shield out the eye here. This field would shield out this eye here to try and treat the tumour there. But there are limitations to this approach. As you can see, one of the limitations is that there is quite a lot of dose in and around the area that you're trying to give radiotherapy to. And secondly, it's not very conformal. So this red area is the area that we're actually trying to treat. And this area, when we're given quite a reasonable dose to areas here, because as I said from the start, that tumours don't come in nice geometrical shapes. And here there's the optic nerve, and we'd really rather try and spare that if we possibly could. So we need to be able to treat brain tumours with greater conformality. And can we do that? Well, we can with newer techniques such as intensity modulated radiotherapy or IMRT. And the way that this works is that you don't give the same dose across the whole beam. Particular parts of the beam gets more dose, and therefore you can shape your beam. So here's the plan I've just shown you with the optic nerve here, and here you can see that you've managed to shave the dose, treatment dose, away from that optic nerve, thereby sparing that optic nerve. And in this case, you could give perhaps a little bit more radiation to the tumour because you can avoid the normal structure that's lying there. And again, this is just more pretty pictures showing the same thing. So this is conformal radiotherapy with a reasonable dose in these areas. And you can see this is the same dose wash, and you've actually spared quite a lot here. But more importantly with IMRT, you've managed to shape the dose to the tumour to the shape of the tumour. Just very briefly, because I think that most people, whenever we talk about radiosurgery, many times MDT, we have a brief discussion about radiosurgery. Radiosurgery is essentially the use of large fractions of radiotherapy to very small volumes of tumour, and they're given in much larger single fractions. So often it's only given over 3 or 4 fractions as opposed to the very, very small fractions that we give with conventional radiotherapy. And there is a size constraint, so they're usually quite small lesions. Cyberknife is also something that's very popular at the moment, just in terms of people are starting to hear about it. And this is essentially radiosurgery, but rather than needing a frame to know exactly where you're treating, this is done much more like conventional radiotherapy, so just with a mask, and you can treat both brain tumours but also tumours within the body. So going back to IMRT, and actually even with the use of Cyberknife, there are limitations to the use of IMRT, and I just want to outline them to you. So these are the pictures I showed you before, and remember I was saying that look how lovely it is that I can hollow little bits out, and it's much more conformal than 3D radiotherapy. But what I didn't say to you is actually this is 30% isodose, or it's about 30 gray, but this is the 10 gray isodose. So the price of getting very conformal radiotherapy here is that you end up treating more of the brain to a lower dose of radiation. And that's true of all IMRT techniques, and that's true of the Cyberknife techniques as well. And the thing is it important? Is it clinically significant that we're treating more of this to a lower dose? Well, I think the honest answer is we don't know 100% that it is. But somehow instinctively, as a radiation oncologist, if you can get away with treating something with no dose, it is much better than treating something with a little bit of dose. So that is why there is a lot of interest at the moment in proton beam radiotherapy. Protons are positively charged particles, so they're not X-rays, but they've got something very special about them. So this is an X-ray energy curve, and you can see that in order to treat a tumour that's lying here, there's an entry dose, but there's also an exit dose, and that explains that 10 grade dose bar that I showed you just now. The thing about protons, however, is they deliver their dose, and they deliver the maximum energy, and within a few millimetres, there's no dose. You have to remember there's still an entry dose, so the protons have to get in somehow, but there is no exit dose. What does this mean clinically? Well, this means clinically that here is a tumour in the eye. Now, just to reassure you, if we were treating this conventionally, we wouldn't actually treat this like this with a single field. This is really done for theatrical effect, so you can actually see that with protons, there really is a very sharply defined cut-off. And I know that I showed you some pictures before and said there was a very tightly defined cut-off, and I showed you some pictures later on and said actually it depends where you set the dose. This is actually at a 10% dose level, so you can actually see that really the dose doesn't travel any further, and it does here. There are lots and lots of pictures like this around. This is a picture of craniospinal radiotherapy, for example, and in conventional craniospinal radiotherapy we can see that there is an exit dose associated with the radiotherapy, but with protons there isn't. Is this all just theory, or can we actually show that this happens clinically? Well, we can show that it happens clinically. So here you can see that this is a MRI prior to radiation. This is what was presumed to be treated. This is proton radiotherapy, and you can see this is where they thought the dose would finish on this line here. In a growing child, you'd never put a radiation field that stopped halfway through a vertebral body, because half the vertebral body would grow and half wouldn't. This is either an adolescent or adult. But it's a very elegant illustration of, you can actually see the marrow signal here has changed. So the dose did stop where they thought it was going to. So currently we don't have any proton facilities in the UK. There are plans for centres in Manchester and in London to be functional and treating patients by 2018. Currently, children in the UK, however, can get proton radiotherapy. There are a group of indications, and brain tumours forms a large part of those indications, to refer patients abroad. If your patient has, or your child has one of these is on the indication list for proton radiotherapy, then your clinical oncologist will refer you to the National Reference Panel. They will look at the case, decide that proton radiotherapy is indeed useful for your and efficacious, and then you will be funded, or you and your child will be funded to go abroad for proton therapy. And I think our next speakers are going to discuss that in more detail. Just so that you're aware that proton radiotherapy isn't a question of just flicking a switch and the machine comes on and you treat them. This is a cyclotron, and that's where the protons are manufactured, spun around very fast, and a person would be about this high up off the floor. So it's quite a large thing, probably fill half this room. The protons then accelerated along a beam line. As they come into the treatment room, they need to be tuned, and then just as with normal X-ray, we would like X-ray or photon treatment, we'd like to be able to have the ability to treat all around the patient from any angle. So we have a gantry-based system. This gantry is about 3 stories high. Again, a person would be about this high off the floor. Didn't have a picture with the person in it, which just makes you think about the sort of size of the facility and the treatment room. And however, you don't see, if you were the patient, you wouldn't see all this, because it would be quite frankly terrifying. And so what you see is something that looks much more clinical and much more like a normal treatment room. But behind that is all of this. So this is why protons aren't widely used. It's not just a question of buying a machine and flicking on a switch. It's a whole facility. So going back to the start of the radiotherapy decision to treat or decision to treat, the challenge ahead, as I see it, is once we've made the decision to treat with radiotherapy, which technology we use, and which technology we use not only depends on things like the actual tumour and where it is, it also depends on all the surrounding care. There is no point in having state-of-the-art radiotherapy if you've taken your eye off the ball and you're not liaising properly with your paediatric oncologist and giving good chemotherapy in a timely fashion, and you're not liaising with your surgeons to get the best surgical outcomes. So, thank you very much for your attention.